Salam alaikum to everybody. Well, my goal today will be to share some, we have the president. Oh, thank you. I can't believe I have the president at my service here. Yeah, there you go. I can move around. Thank you. So my goal today will be to share some thoughts with you about what's new in the management and our understanding of psoriatic arthritis. Yes, as Professor Selmi told us, we're lucky. 2022 is a good year to have psoriatic arthritis. Of course, we would prefer if nobody had psoriatic arthritis, but still, if we compare the weapons we have today with what we had 5, not even 10 years ago, I mean, we're extremely lucky. We could only dream of such treatments. If I can have the slides, please. So the other thing is that in the case of psoriatic arthritis, there is really very limited certainties. Most of the sentences that relate to psoriatic arthritis start with, "We really don't know." We really don't have that exact piece of data. So, there you go. This is where we will go through. We'll start with a brief overview, which Professor Selmi already started briefly. Then we'll look at what the new recommendations tell us. We know that in the past few years, we had not 1, not 2, but 3 sets of recommendations for the management of psoriatic arthritis, which could be confusing in many ways. And then, of course, we'll talk about IL-23 inhibition. And we'll focus on the efficacy and safety of guselkumab in the treatment of psoriatic arthritis by getting data largely from the latest ACR meeting, which took place in November 2021. And finally, I'll try to answer, or I'll address to myself 3 burning questions, which you will have to wait until the end to find what they are. So yes, psoriatic arthritis is complicated, like we heard. Yes, psoriatic arthritis is like a lasagna. If you ever tried a lasagna, if you know what Italian food is, a lasagna is made of layers of pasta, made of layers of dough. Psoriatic arthritis is virtually the same. And the baseline layer is enthesitis. That's where it all begins. Enthesitis is where it starts, the disease starts, and it starts because entheses contain T cells that are capable to listen to interleukin-23 by expressing the interleukin-23 receptor. Interleukin-23, which comes from the gut microbiome, which looks a lot like the inflammatory bowel disease one, from HLA-B27, which we know is associated, not as strongly as in ankylosing spondylitis, but it's associated with psoriatic arthritis. And finally, biomechanical stress, meaning that walking on our lower limbs is eventually what leads to the development of enthesitis. So that all leads to the production of interleukin-23, which commits T cells to become Th17. I had a very fruitful discussion with my friend Dr. Gamal a few days ago about the fact that the consequentiality of interleukin-23 and interleukin-17 is not a dogma. It's not mandatory, but still, I do firmly believe that interleukin-23 at least largely influences the development of interleukin-17 and TNF-alpha and interleukin-22. And that leads in different proportion to the 6 main domains of psoriatic arthritis, 2 of which are on behalf of our friends the dermatologists, skin and nail psoriasis, 4 of which we need to evaluate. 1 is counting joints like we do in rheumatoid arthritis, but then we count enthesial sites, then we count dactylitis, and then we also evaluate axial disease, which have very variable type of proportion in our patients. Another layer in the PSA lasagna is made by metabolic comorbidities. A third of our patients with PSA will be obese. there will be a higher risk of developing diabetes, non-alcoholic fatty liver disease. All of these conditions need to be kept in mind when we choose a treatment, because they may influence, for one, they may influence the infectious risk of our patient. And the last layer is associated conditions. Associated conditions are conditions that share some immunological mechanisms with PSA, and that's namely, especially inflammatory bowel disease, particularly Crohn's, and acute anterior uveitis. All of these need to be addressed. We need to cut through all the layers of each of our patients with PSA. And that's what recommendations try to tell us. These are recommendations, not guidelines, so they're not telling us what to do, but more like what we should probably not do, in a way. And I will briefly touch upon the Euler and the GRAPPA recommendations. I have to admit, number one, that I come from Europe, so I'm biased towards Euler, and number two, that I'm part of GRAPPA, so I'm biased towards GRAPPA. That's why I am less prone to apply the ACR recommendations, at least to my practice. The Euler recommendations came up putting basically after the failure of conventional synthetic DMARDs for articular manifestations and without conventional synthetic DMARD for enthesial disease directly onto a biologic. And the Euler recommendations put TNF-alpha inhibitors, IL-17 inhibitors, and interleukin-12/23 inhibitors on the same level without any preference, if not when the skin is involved. And we'll come back to that in a second. If the patient has predominantly axial disease, again, conventional synthetic DMARDs are skipped entirely, and the biologic DMARDs of choice will have to be either a TNF inhibitor or an IL-17 inhibitor. What about GRAPPA? GRAPPA is less linear. The GRAPPA recommendations, in my opinion, fit better into the way we think whenever we see a patient, because every patient we face in our clinic will have one dominant domain. I'm sure you can think of any of your patients and think, oh, this guy is a predominantly synovitis. Oh, this guy is predominantly axial, or perhaps the skin. That's what the GRAPPA recommendations go through. That's why, depending on what the dominant domain is, you will find different type of levels and type of treatment. Which also tells us that these recommendations are based on a mechanism called grade, which will advise strongly in favor, advise strongly against, and some shades of gray in between. So we've seen where IL-23 inhibition fits into the current recommendations, but what are the data for recommending the use of guselkumab in patients with PSA? Well, I need to tell you briefly about the 3 studies that led to the approval of guselkumab in the treatment of PSA. Number 1 is DISCOVER-1. DISCOVER-1, a little counterintuitively, includes patients with active PSA who could have been exposed to an anti-TNF, and that was about a third of the patients. And then these patients were randomized to 3 treatment arms. Guselkumab every 4 weeks, guselkumab at week 0, week 4, and then every 8 weeks, Q8, which, by the way, is the approved regimen currently for psoriatic arthritis or psoriasis, and then a placebo arm with an early escape at week 16 or an automatic switch to Q4, guselkumab Q4 at week 24. The study went on for 1 year, 52 weeks. Primary endpoint, however, were ACR 20 at week 24 with a whole lot of secondary outcomes, which you see listed there. DISCOVER-2 is only biologic naive patients. Larger number of patients, same structure, longer study, 100 weeks, 2 years. That's why all the data you will see from now on going to 2 years will be derived from DISCOVER-2. And then comes COSMOS. COSMOS was done specifically to address patients that had failed 1 or 2 anti-TNFs to begin with. And these only had 2 arms, which was placebo and a Q8 arm, which again is the approved current regimen for the treatment of psoriatic arthritis. The results. Well, this is the curve for the ACR20 response all the way to 2 years. I want to point out two things. Number one, this is a non-responder imputation. So, as you well know, this is a more conservative way to look at data because patients who are dropped out of the treatment, and that was only 12% of the initial study population, are considered to be treatment failure, number one. And number two is what you see there. You can see that the final figure, which is about 75%, escapes the current 20, 40, 60 rule that we all have in our mind for ACR 20, 50, and 70. And number three, if you wish, you do see that by week 24, the primary endpoint was indeed met, but the curve continued to increase over the subsequent months. And that remains stable. That's another important issue when it comes to especially younger patients, which have been there's a lot of debate about for interleukin-17 inhibitors. If we look at the data closer, one thing pops out, which is the fact that if you screen patients in the DISCOVER-1 trial according to whether they had been treated with an anti-TNF or not before entering the study, basically you see very limited differences in terms of ACR response. That's interesting. We used to think of TNF inhibitor failures as hard patients, as the steepest mountain to climb. Yet, these data seem to tell us that patients that failed anti-TNF probably have a non-TNF-based disease which will respond equally to interleukin-23. And this definitely needs to be looked at from closer, but the COSMOS study seems to confirm that. COSMOS study, let me remind you, included only patients failing 1 or 2 anti-TNFs before entering the study. And as you can see here, the number of patients achieving ACR20 by 6 months recalls a lot what we've seen for the DISCOVER-1 and 2 trials. What about enthesitis and dactylitis? We know these are other difficult domains to treat. On your right-hand side, you will see how many patients were free of enthesitis by 6 months, 24 weeks, or 1 year. And what you see there is that basically there is no dose effect, like we've seen for ACR20. Using guselkumab every 4 weeks, Q4, or every 8 weeks, Q8, doesn't really lead to an enormous advantage in terms of enthesitis resolution, which approximately 58% of patients being totally enthesitis-free by 1 year of treatment. Similar observations can be made for dactylitis, which, by the way, the EULAR recommendations put on the same level and in the same group with enthesitis, in which you see that 3/4 of patients will be free of dactylitis by 1 year, regardless of the schedule of guselkumab use. If you look at the COSMOS data, I'm sorry, these are in the inverse order. On your left-hand side, you see how many patients had a negative as a 0 Leeds enthesitis index, which means we're free of enthesial sites being painful. And again, 56% of patients by 1 year of treatment after failing, remember, 1 or 2 anti-TNFs, were free of dactylitis and enthesitis. But we all know, looking at just one domain, probably it's not the ideal way to look at psoriatic arthritis. So what about minimal disease activity? Well, minimal disease activity, as you know, is a yes or no response and includes the achievement of 5 out of 7 items, also including the skin. Well, what we see here, again, is that dose effect is virtually absent, and that if you continue to treat patients from 6 months to 1 year to 2 years, you will continue to see an increase in the proportion of patients achieving MDA, which will be about 37 to 40% at 2 years. And then comes axial disease. Axial PSA is now very popular, is a big field for investigation. There is dedicated studies looking at this, and the current understanding is that axial PSA is not identical to axial spondyloarthritis. From a clinical perspective, from a pathogenic perspective and also from a treatment perspective. And that's also shown by the data of the use of guselkumab in patients. It's a post-hoc analysis. So it's got several methodological limitations, but still tells us that in those patients with PSA and imaging proven sacroiliitis, you will see an improvement of all 6 items of the BASDAI. So the peripheral items, enthesitis and joint pain, but also fatigue, and more importantly, spinal pain. So despite the fact that interleukin-23 blocking seemed to be ineffective in ankylosing spondylitis, these data tell us that the use of an IL-23 blocker may have some effect on the axial manifestation of PSA. Again, we need dedicated study, but that's definitely something to be considered and probably not stopping us from using this type of approach in patients with axial PSA. All right, from here you seem all awake, which is a great success after lunch. 3 burning questions. I know you're asking the same question. Number 1, is guselkumab safe? And the answer came again from the ACR data. These data combined psoriatic arthritis and psoriasis studies, so the Discover 1 and 2 and the Voyage 1 and 2, and tell us 2 messages. Number 1 is that the safety profile between the 2 treatments, between the 2 conditions, is virtually identical. And that's good news, because in rheumatology, we tend to treat patients with additional drugs that our friends, the dermatologists, don't use that much. And I'm not sure you can see that there, but the signals for infections, serious infections, adverse events leading to treatment discontinuation, major cardiovascular events, and malignancies were virtually absent. Meaning that the safety profile, of course, there's no placebo comparison because placebo was dropped after 24 weeks, but still, we do see a very good signal. And if we put all the data about psoriatic arthritis together, that's phase 2 plus Discover 1 and 2, we see the very same type of message. And again, these are data that were presented at the virtual ACR in November. All right, second burning question. How do guselkumab and ustekinumab compare? Because we had experience with Stelara, with ustekinumab. Is this the same type of mechanism? We know that ustekinumab blocked interleukin-23 and interleukin-12, while guselkumab only blocks interleukin-23. So how do they compare? Well, let me tell you, there will not be a head-to-head study anytime soon, but with an indirect comparison, putting together and combining and matching patients from studies with guselkumab and studies with ustekinumab, it's been shown that in terms of ACR 20, 50, and 70 response, guselkumab was superior to ustekinumab, both in biologic naive and in biologic experienced patients. And this is something definitely that needs to be confirmed in real life. It needs to be confirmed in our daily practice, because that's what matters at the end of the day. Finally, the most important burning question: which patient for which treatment? If we put 2 rheumatologists with 1 patient in 1 room, probably they would come up with 3 different treatment choices, because that's what psoriatic arthritis is all about. That's why the only honest answer to this question is we really don't know. But if we ask our patients, which is always a good thing to do, we will find out that before efficacy, what they care about is safety. And that's something that needs to be kept in mind. Daniel Kahneman won the Nobel Prize 20 years ago for showing that we have 2 ways of thinking. One is fast, and I consider that to be efficacy. We want people to feel better. We want people to be excited, to come back and say, "Thank you, doctor, you made all the difference in the world to me." But then we have a slow way of thinking, which is the more elaborate one. And that's when we think about safety. Yes, we do want the patient to be happy, but we also want the patient to be to be safe. So the only answer to that question is consider everything. That answer changes for every single patient that will go through your door. Consider all the musculoskeletal domains. Don't just count joints. Let's consider everything. A patient in very low disease activity could still have, for example, one enthesial site being painful. And if that enthesis is a heel, I mean, the quality of life of that patient would be very impaired. Second, yes, we need to also look at the skin and nails. And then consider safety. Consider metabolic changes, particularly obesity. We know that obesity impacts the efficacy, for example, of TNF inhibitors. And that's something we need to consider when we decide a patient. And finally, consider associated conditions. Uveitis is pretty neglected today by clinical trials, but IBD is a very important field of investigation. And that's something that will impact our treatment choices. Since, for example, the GRAPPA recommendations strongly advise against the use of interleukin-17 inhibitors in patients with IBD. So I'm done. I thank you very much for your attention. I'm hoping there will be a nice debate, and I say shukran to you and to the great people I have the privilege to work with in Milan. Thank you very much.